Good evening, everybody. So today it's my great pleasure to introduce you Dr. Siddharth Shekhar Mishra sir. So who is one of the topmost faculty for PSM in the country. And because tuberculosis is such a complicated topic, so not only the clinical aspect, the programmatic aspect is much more important. So if I see 2 or 3 clinical questions regarding tuberculosis, simultaneously 10 programmatic questions will be asked. So let it be in your theory exam or in your practical exam or any entrance exam. So tuberculosis clinical and programmatic management part will be very, very important. So without wasting much of the time, I would like to call upon Siddharth sir to start this session, who will be dealing with the most important program in our country, National Tuberculosis Elimination Program. Over to you, sir.
Thank you, sir. And good evening, resident doctors and the students who would be listening this particular session. My dear students, we are talking about probably the national disease of our country. Now, if you ask me, tuberculosis is one disease which probably is the bread and butter till now, not only for MBBS graduates, but even for the other systems of medicine. And to a very big extent, we know that India is the global capital for tuberculosis. And that is where this program, which was earlier called as RNTCP, has now been renamed as NTEP. Now, let us first understand why did they rename it? Because globally, we are looking into eliminating TB by 2030, global. But India, we are looking to eliminate it by 2025. So 5 years before the global guideline, we are looking to eliminate tuberculosis. Now, whether that happens or not, that we do not know, but definitely the government's political will and commitment is highest for this disease as of now, if you look at a global level, because India has the highest burden of tuberculosis. The first reason is today itself, India has been declared as the most populous country of the world, officially defeating China. So you can understand, since our denominator, that is the population, is so high, automatically we will have the largest case burden of any disease. Yes, and that holds true for tuberculosis, that holds true for diabetes. Now, the reason I'm specifically mentioning both the diseases because TB and diabetes also go hand in hand. Now, this is the first thing. Whenever you get a TB patient, or you should always do a random blood sugar, and if it is above the required range, you should be asking for a fasting blood sugar, ppbs, HbA1c. Similarly, reverse. If you see a diabetic patient, do ask him whether he has or she has symptoms of tuberculosis, because they are like cousins. They move hand in hand. Now, I would be dealing mainly with the programmatic stuff. Now, this is one thing which you are asked either in form of an MCQ or in your long question or a long case, a short case, it will always be asked. And trust me, if you fumble in TB, you're going to fumble in the exam, because it is a sin for an Indian medical graduate or postgraduate not to know tuberculosis. So that is the reason even the clinical teachers love to ask you programmatic aspects. Okay. So tuberculosis is called as the barometer of social welfare. It was declared a global emergency by WHO in the year 1983. Government of India has declared tuberculosis as a notifiable disease on the 7th of May 2012. Elimination criteria is less than 1 case per million. Currently, India is having it around 2000 to 2200. Exact number is 2170, but this value changes. So I would rather tell you to remember it as 2000 to 2200. This is the caseload what is there in Indian context. Now, if you look into the most recent data, this is the data which is coming from the TB report, which was released on March 24th, 2023. Now, what is March 24th? World TB Day. Now, why it is celebrated as a World TB Day? Yes, guys, can anyone tell me why it is celebrated as the World TB Day? Anyone? Yes. Okay. So, answer to this, anyone? World TB Day? Because it marks the anniversary of the discovery of tuberculosis, or it is the birthday of some special scientist who discovered tuberculosis. Yes, guys. Why do we celebrate World TB Day? Bharat sir, any answers we are getting from the students?
Mentioned it as Robert Koch. So they're
Excellent.
not specific about what event. Is it his birthday or the day that he has shown the world that it is due to tuberculosis?
Okay. So guys, this is your homework probably, where we would be waiting for an answer from your side. Why do we celebrate 24th March as the World TB Day? Okay. So on this 24th, the data was released. Now you understand India does not give a data of a very updated one. So we have the data of the 2022 because that is what is released in 2023. Now they say there are 210 TB cases, incidents, that is number of new cases per lakh population. But the notification is only 172. So you can understand that we do not notify all the cases. And that is the reason that target for notification is set at 90%. So guys, this is the first question which as a postgrad you can be asked. What is the target of notification and how much did we achieve? As an undergrad, you will get direct data that incidence is 210 and 172 is what is actually reported. Now, there was a National Tuberculosis Prevalence Survey 2019-2021, which estimated that there is tuberculosis infection almost 31% among the adult population. Now, can anyone tell me the difference between a TB infection and a TB disease? Yes, guys. Difference between a TB infection and a TB disease. Now, just I'll give you a hint. I am also infected with TB. Bharat sir is also infected with TB, and all of you who are listening are definitely infected with TB because when we go to the hospital setting, we do get the infection. So there is TB bacillus somewhere hidden in my body. Yes, that is what is TB incidence of infection, but we don't suffer from the disease. We will suffer from the disease when we will be immunocompromised. Now, earlier this value stood at 40%, but then in the recent national survey, it has come down to 30%, which is a very good indicator if you talk about overall programmatic efficiency, not of TB program, but overall related to hygiene. Because the overall hygiene has improved, this TB infection has come down. And this dates back to a very important theory, which told that the TB incidence dropped in the Western world, not due to BCG vaccine, not due to anti-tubercular drugs. It was basically due to sanitation and hygiene. Can anyone name me what is the name of that theory? Can anyone name me what is the name of that theory? Yes, guys. Theory of hygiene, which is related to your tuberculosis incidence drop. Anyone? I'll be asking you questions to make it more interesting because I want some answers from you guys. Bharat sir, any answer coming up?
No, sir. They have given what is meant by latent TB. So infection may be latent, so just infection, not an active disease.
Okay. So here comes the second homework for you. Name of the theory related to hygiene which led to drop in TB cases. Now, why am I asking you this? This is a very important question. If you get some examiner who is around 60-65 in age, they love to ask this theory. Okay. Now, this is the recent logo of NTEP. The vision is TB Mukt Bharat, TB Free India. Now, this is very easy. With the current government, they have made everything Mukt. Anemia Mukt, tuberculosis Mukt, leprosy Mukt. So it is very easy to remember. It is TB Mukt Bharat, National TB Elimination Program. Now, this logo has got multiple components, yes, which explains us the importance of this logo. Okay, like we have the country's flag. Yes, this basically symbolizes that this is the pride of our country, that we run such an important program at the national level for control of tuberculosis. You can see that the flag is swirling. Yes, over here. It's not a static flag, it is a swirling flag. Yes, this means that the people associated with the program, whether the patients and the people like us who would be noticing, are given importance. So basically it symbolizes pride. The line TB Mukt Bharat is symbolic that if together we stand, we can defeat TB. Now, if you see, there is a yellow and red color in the beginning. It basically talks about the emotions of people, red indicating a danger, whereas yellow indicating positivity. Now, the circular unit is written because basically our program is in this manner. It is like a circle from top to bottom. We will relay from the head office in Delhi to the most peripheral center and reverse, because even at a village level, the data is captured on the Nikshay app, which is relayed to the Delhi government. Yes. Now, the human being over here basically is looking happy, is celebrating. Yes, this shows that we can win over TB. So if a person who is interested in the program might ask you to explain this logo as well. Yes, the key features. First, end TB by 2025, 5 years before global guideline. Case finding. Now this is very interesting. The case finding, we are doing all the three types of case finding: active, passive, intensive. Passive finding is voluntary testing. I'm a person coughing a lot, I'll go and get myself tested. Intensified case finding, this is basically done of TB screening in COPD patients, in HIV patients, in diabetes patients. Active case finding is done in vulnerable population, like those who would be staying in the same household with a TB patient. The next important key feature which has come out is universal drug susceptibility test for every patient, whether sputum smear positive or negative, sensitive or resistance, new or old. Any TB patient would be subjected to a universal DST. Yes. Now, I had already told you that on the 7th of May 2012, tuberculosis was made a notifiable disease by the government of India. If as a doctor, you might be an allopathic doctor, or you might be an Ayush doctor, you might be a health worker, you might be a private doctor, government doctor, you need to notify the TB case to the district tuberculosis officer within 1 month of diagnosis. Now, if you do, you will get money. If it is drug sensitive new, you get 1,000. If it is drug sensitive previously treated, you get 1,500. If it is drug resistance, you will get 5,000. So you will get money. But if you do not report, it is a punishable offense under section 269 and section 270 IPC, leading to a jail sentence of 6 months to 2 years with or without fine. Now guys, please do not take this lightly, because 1.5 years back, the first doctor was put behind bars in Ahmedabad in Gujarat for not notifying TB case. So please be careful. This is not a very casual thing which the government has started. Now, when we talk about the treatment for drug sensitive, whether it is new or previously treated, intensive phase 2 months of HRZE, and the continuation phase is 4 months of HER. Now we give 7 days a week daily therapy, no more alternate therapy. Now over here you can see it is 4 drugs. Now it is a FDC. Now what is a FDC? In a single tablet you will have all the 4 medicine in the dose of 75 milligram of isoniazid, 150 milligram of rifampicin, 400 milligram of pyrazinamide, and 275 of E. Now, since it is 4 tablets, it is a bigger tablet, and the name of this tablet is anti-TB schedule 9. Whereas in continuation phase, it is only a 3 FDC because we only give HER. It is a smaller tablet and it is an anti-TB schedule 10 drug. Now, what do I mean by 9 and 10? Look over here, guys. On this, it is written as 10. So it is 3 FDC. On the cover, over here it is 9, written 9. So it is 4 FDC. Now, since it has 4 tablets, the tablets are bigger. So if both the strips are given in this form, you can understand this one is 4 FDC, whereas on this side, it is 3 FDC. Okay. So this is anti-TB schedule 9. This is anti-TB schedule 10. So many times you can get a spotter question for anti-TB drugs. When we talk about the pediatric dosing, we have 6 categories, whereas in adult, there are 5 categories. Now remember, whether it be pediatric or adult, we are going to make the change in dosage the moment there is change in weight. Earlier in adult, this was not the guideline, but now they have changed both for adult and pediatric. Weight band change the dosing. Yes. Now, if you look into this, that is what I mentioned, that for adult or for pediatric age group, any change, immediate change of the drug schedule. Now, follow-up. Earlier, the follow-up was very complex. Now, the follow-up is very simple. For new and previously treated drug-sensitive TB, the sputum smear has to be done at the end of intensive phase and continuation phase. If at the end of intensive phase, the patient is sputum smear positive, we are not going to extend the intensive phase by 1 month. We will immediately start continuation phase and send the sputum for DST immediately. We will weigh the patient every month and chest X-ray only if it is required. For drug resistant, the sputum smear is done monthly at 3, 4, 5, 6, 7 and at 3 monthly interval at 9, 12 and 15. Now remember, any TB treated patient has to be followed by the health worker for 2 years to check for recurrence. So these are important points for follow-up. TPT. All household contacts of pulmonary TB have to be given TPT. Second, high risk group have to be given TPT. Yes. So all household contacts. This is a very important thing. Not only pediatric contacts. Earlier we used to say only pediatric. Now it has been changed to all household contacts. Now to look into the treatment compliance, we have NICSHI, 99 dots, and a new technology which is coming up, that is RTMERM. Now when we talk about NICSHI, we know there is just one portal called as NICSHI. So it is a IT tool basically to look into the surveillance. Apart from this, we have NICSHI Aushadhi. NICSHI Aushadhi is the drug distribution and management system. Third NICSHI, NICSHI Poshan Yojana. Every TB patient is given 500 rupees per month to meet the additional expense related to nutrition, because you know in TB there is weight loss, they need to eat more, yes, and for transport, that is to come to the facility to collect the medicine. In tribal area, they give 750 rupees. This is NICSHI Poshan Yojana. Now, 99 dots. It's a very good system. It is an online monitoring system where when you remove the TB tablet, an unknown number is visible. The patient has to give a missed call on this unknown number. The moment a missed call is received, on the computer system which is there in Delhi, there is a color change from green to red. This helps a person sitting in Delhi to know whether a person in a distant rural place has taken the medicine or not. If this color change does not happen, then automatically SMS is sent to the concerned supervisor of the patient that this person has not given a missed call. Now, why it is called 99 dots? Because only this is 99% efficient only. The patient might throw away the tablet and just give a missed call. You never know. We Indians are smart in it. Third, the RTMERM device. Now, this is a device. We will keep the tablet over here, close the lid. This device can tell you the date and time when each medication was opened. Now, this helps to catch even more people who are actually taking the medicines and whether they're taking the medicines on time or not. This is a very recent technology. It has not been yet launched in the program. Expected that this year they might be launching this. So if your professor is an advanced update person, he or she might be knowing this. TB, HIV, 5 components. CBNAT for all. Daily FDC for HIV and TB. 99 dots. Pharmacovigilance because they have more and more of side effects. And isoniazid preventive therapy. So 5 things for TB, HIV. Yes, guys? Let us look into the programmatic aspects. We have the National Strategic Plan for TB Elimination 2017 to 2025. Vision, TB Mukt Bharat. To achieve a rapid decline in TB by 2025, it has 4 components. Detect TB, treat TB, prevent TB, and build capacity so that we can tackle TB. It is also called as DTPB approach. Yes, guys? So, at a global level, 2030, at India, 2025. So, we are setting up targets for this, that there should be zero catastrophic expenditure. Zero catastrophic means normally when a person gets TB, they have to sell off their properties and houses to actually get treatment. That shouldn't happen. Reduction in TB incidence rate as compared to 2015, we want to bring down by 2025 a 50% reduction, and by 2025 a 75% reduction in TB deaths. You never know that will be achieved or not, but we are waiting for it. Expected outcome by 2025, 80% reduction in TB incidence, 90% reduction in the TB mortality, and 0% patient having catastrophic expenditure. Now, the TB districts with HIV burden and with drug-resistant TB have been divided into various categories. Category A, high TB burden, when the total TB case notification rate is more than 180 per lakh population. You could see that currently we are at 172. So those districts which are reporting more than 180 per lakh are category A. Category B, 10% proportions of known HIV positives among TB patients are tested for HIV. More than 25% proportion of relapse out of incident smear positive cases, high drug-resistant TB areas, category C. Category D, annual TB suspect examination rate of less than 400 per lakh population. Category E, when none of the above criteria are met, that is average. Category F, annual suspect examination rate more than 1200 per lakh population, and the total case notification rate is less than 80 per lakh population. High case finding but low total case notification rate. Now this is absolutely mug up, so you might get a short note on this directly in the exam. Now recently our Honorable Prime Minister has launched the Pradhan Mantri TB Mukt Bharat Abhiyan, PMTBMVA, Nikshay Mitra initiative. So what is this? Nikshay Mitra. Normal people like us, we can adopt TB people. This is called as Jan Bhagidari, and we will bear the expenses related to their treatment, food, travel. So this will help the poor people to actually take treatment without any kind of challenge. This is the TB framework. We start from the Ministry of Health and Family Welfare. We have the National TB Cell. Then we have the State TB Cell, the District TB Center, the TB Unit, the Designated Microscopic Center, the Peripheral Health Institution, and then we have the Ayushman Bharat. TB Unit has to be there 1 per 1.5 to 2 lakh 2.5 lakh population. DMC should be available 1 per 1 lakh population. Now, so we start over here with the central TB division, then there is the state TB officer, then there is a DTO, district TB officer, then there is a TU, tuberculosis unit, then we have a DMC, then we have the dot center. Monitoring in the intermediate reference laboratory IRL, we receive 10% sputum slides from the DTC. So we have to test for 10%, and random blinded random checking, 10% slides are checked, both positive and negative. So just remember 10% is the cutoff to ensure quality in the TB program. Yes, guys. Now ARTI, as we had discussed, it is a proportion of population which will be primarily infected with TB in course of 1 year. It indicates incidence of TB infection. It is the best indicator of trend of TB affected in the current community. Most important for magnitude of TB problem, the ARTI currently in India is 1 to 2%. So every year this is where it is going up. ARTI in children is 1%, whereas in adults we just saw the new data has come up 31%. Earlier it was 40. How do we collect the sputum? 2 samples are collected within a day or 2 consecutive days. One is called as on spot, one is early morning. It should be 2 ml in quantity, mucopurulent. Saliva should have less than 10% squamous epithelial cell. The results have to be given within a day. Early morning sample is labeled as B. The on spot sample is labeled as A. Labeling is done on the container. So suppose this is the container, the labeling will be done over here, not on the cap, because I can remove the cap and by mistake the lid can be replaced. So it is done on the container. Yes, guys. So A and B. Diseases to be screened under NTEP are HIV and diabetes. There is a 24/7 helpline. We should dispose the sputum safely by either burning or using 5% cresol, boiling and autoclaving. The notification by DTO is also done on a monthly basis, even for private doctors. World TB Day theme was yes, we can end TB. That's all from my side, guys. Any questions, please feel free to ask. The reason I'm keeping it short is I know you guys are clinicians, so you won't be too much interested in knowing the programmatic aspect, but trust me, you should know it, because at the end of the day, even as clinicians, your role does not end in your clinics. Remember, if you see one TB patient, there are at least 3 to 4 members in the family of that TB patient whom you have to save from getting tuberculosis, and definitely that neighborhood. As a clinician, it is your job to tell them, please get your family members, because they also need TPT. You have to tell them how to dispose of the sputum. You have to tell them about the benefits they will get, like 500 rupees per month. You have to tell them that this is curable. Please do not leave the medicine midway. Any side effects come to you, because when they go and talk to a ASHA worker or a health worker or a simple medical officer, they might not be that impressed as compared to a clinician whom they are coming and meeting in an OPD. So guys, the change comes from us, and probably this is the biggest change you people can contribute in eliminating TB by the year 2025. Thank you. That's all. Any queries, please feel free to ask.
So thank you so much, sir. That was a rapid and wonderful session covering all the aspects required with respect to program. And as you have mentioned, it will be finally the clinician who will be able to motivate the patient, treat the patient, and make sure there is no community spread. So that's why for tuberculosis, like I tell to my undergraduates and postgraduates, so program is most important than your treatment. So you should make sure you're not only treating the person, you're also identifying other people in his family who are at risk of developing tuberculosis. So students are also very happy with your lecture, sir, as usual. So it has been a, what we call a continuation. So we had the great opportunity to guide them previously. Now it is just continuing in all aspects of their life. So without wasting much of your time, so I would like to thank sincerely Siddharth sir for, in spite of his busy schedule, coming over here and sharing his great views. So now let us see what can a clinician do regarding tuberculosis. So first of all, we'll start with the definition of presumptive TB. So examiners will be very particular regarding the definitions. Presumptive TB means any one of the following. Just 1 minute. Yeah. The patient with any one of the following. So what is this? Fever more than 2 weeks. Cough more than 2 weeks. What is this symptom? So this is nothing but hemoptysis. So there is hemoptysis and significant weight loss, radiological abnormality on chest X-ray suggestive of TB. So if you find any one of the following in a patient in our country, what is this phenomena to be referred to as? It should be referred to as presumptive TB. Fever more than 2 weeks, cough more than 2 weeks, very significant weight loss, radiological abnormality on chest X-ray suggestive of TB. Then previously, it was just identification of TB bacilli. So now the times have changed. Now it is not just identification of TB bacilli, it is also the identification of resistance. So now the most famous movie in our country is RRR. So this is not Rajamouli's film for tuberculosis. It is recognize resistance rapidly. So previously, it was only to identify TB bacilli. Now, whatever investigation we are doing right now, it is targeting, recognizing resistance rapidly. As a clinician, you should make sure you're not just detecting tuberculosis, you're also detecting the resistance pattern for rapid identification of DRTB. So that drug-resistant TB, now the weapon in our hand is upfront NAT. So previously we had only one NAT. Can anybody tell me what is that NAT that we were using previously? It was CB-NAT, cartridge-based nucleic acid amplification test. But now we are having two NATs. So one is CB-NAT, the other is true NAT. So NAT means nucleic acid amplification test. So available or CB-NAT. So CB-NAT is common. It is also called as gene expert. CB-NAT is also called as gene expert. And the new Indian technology. So this is truly Indian. It is true NAT. Now what is the technical aspect? So technical aspects. What is the primary difference that everybody should know? This CB-NAT, it simultaneously detects Mycobacterium tuberculosis and resistance to rifampicin using real-time PCR. So this is more of a single step test, and it not only recognizes Mycobacterium tuberculosis, it also recognizes resistance to rifampicin using real-time PCR within 2 hours. Now coming to true NAT. So true NAT, it is also a quantitative real-time PCR for detection of Mycobacterium tuberculosis. And this also detects rifampicin, but it is more of a two-step assay for tuberculosis. It detects TB in 1 hour, rifampicin resistance in another hour. Apart from this, there is also Gene Expert Ultra, but in program, we are using only CB-NAT or TrueNAT. So the biggest advantage of both these tests is it will detect TB and it will detect resistance to one drug. So which drug? Rifampicin resistance. So it will not only detect TB, but also it is going to detect rifampicin resistance. Now putting it in a very simple manner, where we use CBNAT, where we use TrueNAT. So what is the biggest advantage of TrueNAT? So CBNAT, it is a big mission. It requires uninterrupted power supply and temperature controlled setting. So CBNAT, if you notice, it is a big mission like this. So you can, whereas TrueNAT, it is more of a battery operated and amenable for placement in peripheral settings. See the difference. So this is Make in India. This is TrueNAT. Such a small mission. You can compare the hand of the patient side by side. So in very simple words, the difference between CBNAT and TrueNAT is nothing but difference between a desktop. You can see desktop, you cannot carry it everywhere, and moreover it requires 24-hour power supply. Whereas TrueNAT, it is handy and battery operated, just like, so not her. So I'm referring to this. So laptop. So it is the same difference in practical aspects, handling a desktop versus laptop. So battery operated, which can be carried everywhere, even in a small center, you can handle it very easily. So this is the basic difference between CBNAT, TrueNAT. Now, which will work better? So which is best, CBNAT or TrueNAT? So recent studies done in India. So one sample size, if you notice here, it is about 10,000, another of about 247. Everything have found out the use of CBNAT and TrueNAT, there was no much difference. So it is just like asking this question: who performed better for not to? So is it Ramcharan or NDR? So both have performed equally well. So now when it is tuberculosis for diagnosis, as you know this song, just remember this NAT. So make sure if there is a patient with suspicious of TB, so what is the first test you should send according to national guidelines? Now it is NAT. So your answer should be NAT here. And which is the best NAT? So out of these two people who have performed best, it is very difficult to say. So many studies have shown that the sensitivity of TrueNAT and CBNAT are nearly the same. So let it be any of this test. If you find out it to be tuberculosis, it is tuberculosis. Then coming to the other tests that are helpful in identifying the resistance. So we have line probe assay. Again, line probe assay dividing into FLSA, LPA means first line probe assay. S means second line probe assay. So this is also for detection of resistance of first line drugs, rifampicin, isoniazid. Second line drugs, fluoroquinolones and injectables. Now, if you see CBNAT, TrueNAT, it will detect TB bacilli and resistance to only one drug, rifampicin. Whereas LPA can detect resistance for multiple drugs, rifampicin, isoniazid, fluoroquinolone, second line injectables, etc. And it is generally performed directly on AFD smear positive specimens or indirectly on culture isolates if the smear is negative. Generally performed when there is smear positive smear or on culture isolates if the smear is negative. And the mechanism, the DNA targets are amplified by PCR and hybridized to immobilized oligonucleotide targets. Results can be read visually or using an automated reader. So it will be having a strip, and on that you can see the results. And the time taken is generally 1 to 3 days. So this is also a rapid method, but the time taken is 1 to 3 days. Then gold standard for any infection is culture. Here rapid culture we have liquid culture DST, and the name of the system is called as MGIT. MGIT means mycobacterial growth indicator tube, and it takes about 8 to 10 days for smear positive samples. And to call that there is no growth, you should wait up to at least 6 weeks. If it is a smear negative sample, it will take at least 2 to 6 weeks if there is any growth. But when compared to the solid culture, so this is less time taking. And the advantage with the liquid culture is you can do sensitivity pattern for all the available drugs. Now with this background, previously, whenever I was suspecting a tuberculosis case, my only goal was to search for TB bacilli. But right now, it is not only searching for TB bacilli, so you are digging deep and also you are identifying the resistance. So a day will come, already it has come. You will not just write it as tuberculosis. You will write it as, is it drug sensitive or drug resistant? If it is drug resistant, again, what is the drug and what is the gene responsible for that resistance will also be written in the report. Now coming to the algorithm, whenever you are suspecting a patient to have tuberculosis, so that is nothing but presumptive TB, according to new guidelines, what is the first test? It is NAT. So in majority of the TB centers, it has been replaced to NAT. What is meant by NAT? It is CBNAT or TrueNAT. And in very rare situations, when NAT is not available, only in that situation, we go to a microscopy. And simultaneously, you can take a chest X-ray. Now, the main goal of this algorithm is not only to identify TB, make sure you are identifying resistance at every step. So there can be two possibilities. One is a NAT negative. So this sample is not positive for TB bacilli. Other is NAT positive. And if the NAT is positive, irrespective of chest X-ray may or may not show lesions. This is called as microbiologically confirmed case. If NAT is positive, chest X-ray, irrespective, you can call it as microbiologically confirmed case. If NAT is negative, now depending upon the chest X-ray and other investigations, you have to consider a clinical diagnosis of TB. So if required, you might take a CT scan, you might do a bronchoalveolar lavage, and after excluding all other diseases, you come to a conclusion called as clinically diagnosed tuberculosis or clinico-radiologically diagnosed tuberculosis. So this is not our topic of interest here. Our topic of interest today is if it is a microbiologically confirmed case and if you have found out it to be tuberculosis, I told you now it is not just identifying tuberculosis, you should also identify the resistance pattern. Are you dealing with rifampicin resistant or rifampicin sensitive? Because NAT will only tell you is it sensitive to rifampicin or resistant to rifampicin. Now by chance, if it is sensitive to rifampicin, we don't know whether it is sensitive to isoniazid or not. See, there are two stars in TB treatment. Superstar is rifampicin and the other star is isoniazid. So when we are giving treatment for tuberculosis, we must make sure whether the two stars are working or not, rifampicin, isoniazid. In this patient, because rifampicin is working, next what you should do, you should see whether isoniazid is working. So you should send it for a first line LPA. Meanwhile, you generally start a drug sensitive regimen. But if your hospital is well equipped and you are getting the result within 1 to 3 days, you can wait. But in majority of these situations, LPA arrives after 1 or 2 weeks. Meanwhile, I don't want to make the patient deficient of treatment. I start drug sensitive TB regimen. And after the first line LPA result, is it H resistant or is it H sensitive? Now, if it is H resistant, isoniazid resistant TB. So whenever it is isoniazid resistant, instead of isoniazid, because it is not working, you give another drug called as fluoroquinolone. Now the problem is you don't know whether fluoroquinolone is sensitive or resistant. So what you send here is, you send for second line LPA, you start isoniazid resistant TB, but make sure that fluoroquinolones are working or not. You send for second line LPA and liquid culture DST, the whole panel. Now, if it is H sensitive, you can start first line drug sensitive TB treatment. You can start first line drug sensitive TB treatment. So previously, if it was just tuberculosis, we were starting DSTB. Now, if it is tuberculosis, you need to know whether it is rifampicin resistant or sensitive. If it is sensitive, make sure isoniazid is working. So send first line LPA. If isoniazid is resistant, make sure even fluoroquinolone is working. So you have to send second line LPA and liquid culture DST. Now, by chance, if the patient is belonging to isoniazid resistant TB, the biggest drug or the most powerful drug has become resistant in this patient tuberculosis. So you don't know whether other drugs are working or not. So what you do is, at the first instance itself, you have to send for resistance of all other drugs. So first line LPA, second line LPA, and liquid culture DST. So here we are doing in a stepwise manner on rifampicin sensitive side. So first line, then second line LCDST. Because here the most powerful drug itself is not working, you have to send the resistance to all other drugs. First line LPA, second line LPA, and liquid culture DST, and you have to plan the treatment. Now for rifampicin resistant TB, we are having two regimes. One is all oral regimen or longer regimen, and this also shorter MDR TB regimen. So now shorter MDR TB regimen has also become oral regimen. So this is a 9 to 11 months shorter regimen, whereas all oral longer regimen is 18 to 20 months. So there are certain criteria where you can not give shorter MDR regimen. So if there are any exclusion criteria for shorter MDR regimen, so you should not give shorter MDR regimen. If there are any exclusion criteria, directly go for longer MDR TB regimen. If there are no exclusion criteria, you can start shorter MDR TB regimen. And meanwhile, when these reports arrive, if there is any additional resistance, you have to modify the regimen if there is any additional resistance. So on the rifampicin resistant wing, what we do initially, we send the sample for resistance of everything, first line, second line, and liquid culture DST. And we see, are there any exclusion criteria for shorter MDR TB? If there are exclusion criteria, you start directly longer MDR TB regimen. So nowhere you are delaying the treatment. If at all there are no exclusion criteria, you can start shorter MDR TB regimen. And meanwhile, when you get the reports of first line, second line, and the liquid culture DST, you can modify the regimen according to the resistance pattern. So this is the basic algorithm for tuberculosis in our country. Presumptive TB, first identify whether it is NAT positive, NAT negative. If it is NAT positive, then are you dealing with rifampicin sensitive or rifampicin resistant? If it is sensitive, then you have to find out whether it is isoniazid resistant or isoniazid sensitive. If it is rifampicin resistant, ultimately which regimen the patient should be given? Is it shorter, longer? And if there are any other resistance, you have to modify the regimen accordingly. Then coming to the clinical aspects. Whenever there is a patient with tuberculosis, there can be two forms. One is primary TB, other is post-primary TB. Post-primary TB is also referred in some books as secondary TB, but the best answer is post-primary TB. Now suppose this is your lung. So consider this is your lung. So in primary TB, what is going to happen is, this is the first time patient is getting exposed to the infection. So when anybody inhales TB bacilli, by gravity, it will come to the areas of high ventilation. So where is high ventilation in your lungs? Mid and lower zones. So in the mid and lower zones, this TB bacilli will get deposited. Now because your body had never been exposed to this TB bacilli, it don't know how to fight against this TB bacilli. So what will happen? All the alveolar macrophages will grab this TB bacilli and it will take to the area where an immune response can be generated. So where it will take it to the hilar lymph node. So to fight against this hilar lymph node will swell up. Now this area, parenchymal focus, is called as Gons focus. And when there is a hilar lymph node enlargement, this combination of Gons focus and hilar lymph node enlargement is called as Gons complex. Now, if your body's immunity is good, whatever immunity has been produced from the hilar lymph node, it is coming and destroying these TB bacilli. So there will be spontaneous healing and very rare complications. So this is a TB happening in majority of us. So we might be exposed to TB sometime else because our body's immunity is good. It is tackling this focus very well. And some cells will be stored as memory cells. And once again, if this TB bacilli come into our body, these memory cells will take care. But in few patients, at the time of first time infection itself, there might be defective immunity. So in immunocompromised, what will happen? First infection itself can progress rapidly. So this infection, if there is no proper immunity, it can progress rapidly and can disseminate to the other lung. It can disseminate to the pleura. It can disseminate to the mediastinal lymph nodes. It can disseminate to the brain, resulting in a hematogenous dissemination and a disease called as primary progressive tuberculosis. So if the patient's immunity is not good, it can disseminate and result in a phenomenon called as primary progressive tuberculosis. Now coming to post-primary TB. So here what has happened is this patient might be already be infected with TB bacilli somewhere else. So there might be a previous infection with TB bacilli. Now because his immunity has decreased, these TB bacilli already living in his body might proliferate. So this is either due to reactivation. So reactivation is most common. Reactivation is most common when compared to reinfection. Now, why will TB bacilli reach apex and actively grow there? Because apex is the area of high oxygen tension. So because in the apex, there is increased ventilation perfusion ratio. See, base will have both high ventilation and perfusion. But if you see the ventilation perfusion ratio, which is finally going to decide the oxygen tension, so that is in the apex. So TB bacilli reach the apex and grow actively. When they want to grow actively, they grow to the apex because apex is the area with high ventilation perfusion ratio, which will result in more alveolar residual oxygen. So because of this, in the apex, they start proliferating. So once they proliferate, there can be destruction and a formation of air-filled areas called as cavitations. And this is the active disease, and it can result in frequent complications. And this cavitary disease or active disease have so many complications. Number one, this cavity can rupture. So whenever it ruptures, so all these fragments can go into the pleural space, resulting in pleural infections such as empyema. So whenever cavity ruptures, air escapes into pleural space, resulting in a dangerous complication called as pneumothorax. And whenever cavity is there, it can erode a blood vessel. Erosion of blood vessel. Cavity can cause erosion of blood vessel. Whenever blood vessel is eroded, there can be massive hemoptysis. See here, cavity is eroding a blood vessel, hemoptysis. Cavity is rupturing into the pleural space. Air escapes, resulting in pneumothorax. Whenever cavity ruptures, all this necrotic infective stuff can come into the pleura and it can also cause empyema. And this cavity can later harbor formation of a fungus. So cavity and a fungus, what is this combination called as? It is called as aspergilloma. So the story is not yet over. So all this destroyed lung, there can be bronchiectasis. TB bacilli TB can directly damage the bronchus and result in bronchiectasis. And from these scars of TB, carcinoma can develop, especially adenocarcinoma. So adenocarcinoma can later develop. And all this can heal by fibrosis. So whenever there is fibrosis, that part will not expand. So as time progresses, there can be respiratory failure. Because of fibrosis, there can be pulmonary hypertension. So why there is pulmonary hypertension? Hypoxemia. So whenever there is hypoxemia, there can be pulmonary vasoconstriction that can cause pulmonary hypertension, and that can result in right ventricular dysfunction called as cor pulmonale. So when your lung is not expanding, so whenever there is fibrosis, there can be hypoxemia. So what can hypoxemia result in? Hypoxemia in long run can cause pulmonary vasoconstriction. That can cause pulmonary hypertension. That can cause cor pulmonale. Easily here itself we have discussed 10 complications of active tuberculosis. So there can be massive hemoptysis, pneumothorax, empyema. Later there can be formation of fungal ball, bronchiectasis, scar carcinoma, fibrosis, respiratory failure, pulmonary hypertension, and cor pulmonale. Now this complicated pathophysiology, let me represent with help of simple animation. This is primary TB. First time TB bacilli are coming into mid and lower joints. They are carried to the lymph node, and this lymph node will swell up. So once again, observe here students. First time TB bacilli, where will they reach? Areas of high ventilation, mid and lower joint. So this area is called as primary focus. And once there is lymph node enlargement, this combination is called as Gons complex. So for primary focus, hilar lymph node enlargement, Gons complex. If your body's immunity is good, TB bacilli will be destroyed, spontaneous healing, less complications. If your body's immunity is not proper. So this is what was happening in patients with good immunity, preserved immunity. So what will be the ultimate presentation? There will be mild fever, occasional pleuritic chest pain. So when there is some defective immunity, so what can happen is there can be few complications. So these enlarged lymph nodes, it can also compress the bronchus. So normally, see here, so this is your lung, and there was a hilar lymph node enlargement. So if it is very big, it can compress the underlying bronchus. So whenever this bronchus is compressed, there can be stasis of secretions. So later there can be destruction resulting in bronchiectasis. So this combination of right middle lobe collapse. So this combination of right middle lobe collapse with bronchiectasis, it is called as Brock's syndrome. And these bacilli, they can go into the pleural space, and they can also result in pleural effusion. And when there is no proper immunity at all, so when there is no sufficient immunity, so this can disseminate. So you can see it is disseminating throughout. So all these TB bacilli are going into the lung. So this pleural effusion and right middle lobe collapse with bronchiectasis, so it can happen routinely only. But when there is no proper immunity at all, it can disseminate. So this combination of right middle lobe collapse and bronchiectasis, it is also called as Brock's syndrome. So these are the events that can happen in primary TB. So primary TB, there can be right middle lobe syndrome or Brock's syndrome. There can be pleural effusion. And when there is no sufficient immune response, there can be dissemination. So only way to differentiate whether it is post-TB sequelae or complications of TB. So they say that if it is sputum positive and if there is a presentation, that is complication. Sputum is negative, but still there is fibrosis or there is hemoptysis, then it is a sequel. So happening during the course of disease is called as complication. So once the active disease period has been completed, patient has completely been declared as cured. And the TB infection, those scars later they can also cause hemoptysis. So fibrotic area can easily break up, resulting in what you call hemoptysis. And you can also see in tuberculosis there will be a old healed cavity, so that can later break and result in pneumothorax also. So if it is happening during the active course of the disease, it is called as a complication. Once patient has developed disease, it got healed, and if it is happening at a later date, it can be called as a sequelae generally. Then coming to the secondary tuberculosis, also called as post-primary. Already this patient must have been infected. Once his immunity has been declined, these TB bacilli will go to the apex and they will be actively dividing like this, because apex is the area with high oxygen tension, and TB bacilli love oxygen, and they cause destruction resulting in cavity. So this is nothing but secondary or post-primary tuberculosis. What do you see in this chest X-ray? You see a right hilar lymph node enlargement. And this is a classical presentation of primary tuberculosis. And these can heal spontaneously, and later you can see some calcifications, such as calcified Gons focus, and later the lymph nodes can also be calcified. So in majority, primary tuberculosis is generally harmless. So what do you see in this image? You can see bilateral upper zone areas of cavitations, and you can see some active infiltrate. This is suggestive of post-primary tuberculosis or secondary tuberculosis. Then common in our country is pleural effusion. And pleural effusion, because it is happening outside the lung, within the pleura, it is generally called as an extrapulmonary TB. Only if it happens within the parenchyma of the lung, it is called as pulmonary TB. If it is happening outside the parenchyma, let it be in the pleura also, it is called as extrapulmonary TB. This is a pleural effusion. Coming to the mechanism of TB pleural effusion. Before that, why TB pleural effusion? You should suspect in every case of exudative pleural effusion, because it is most common cause of exudative pleural effusion worldwide. So it is most common cause. And why it is happening? It is actually not due to active infection. It is due to hypersensitivity reaction. Consider this is the lung, and let this be the pleural membrane. These TB bacilli will come into the pleural tissue. So they will be at the pleural tissue, and against this TB bacilli in the pleural tissue, there can be a hypersensitivity reaction. So because of hypersensitivity reaction, fluid will be accumulating in the pleural space. So where are majority of TB bacilli? Majority of TB bacilli stay in pleural tissue, not in fluid. Majority of TB bacilli. That's why even if you take the fluid and see under microscope, you don't find organism. And that's why for diagnosis, it is mostly by ADA. So ADA value, if it is more than 40, we can suspect tuberculosis. If it is more than 70, more confidence to call it as tuberculosis. And which cells are excess? Lymphocytes, adenosine D-minus, ADA. And pleural fluid, because only less bacilli are there in the fluid, culture will only give you 20 to 30%. And if you do a NAT, the sensitivity is increasing to 49.5%. So which is the most ideal sample to identify microorganism in TB pleural effusion? It is not pleural fluid, because TB bacilli are not residing in the fluid. They are residing in the tissue. So the ideal sample, if it is inconclusive diagnosis, is biopsy, is taking the tissue. And which is best? Taking through thoracoscopy when compared to percutaneous pleural biopsy. And the yield with thoracoscopic biopsy is 93.2. So if they ask you which is the best sample for diagnosis of pleural effusion when it is inconclusive, your answer should be pleural tissue. So why will you use sputum here if it is plain pleural effusion? Majority of the situations, sputum will be negative even unless and until there are active infiltrates in the chest X-ray. So generally it is a hypersensitivity reaction. In TB pleural effusion, the ultimate sample for diagnosis will be pleural tissue. So tissue will give you highest yield because the TB bacilli or generally majority are staying in the pleural tissue, not in fluid. Then coming to miliary tuberculosis, it can be classified into two types. So the miliary form. So miliary form of tuberculosis can be classified into two types. So one is classical miliary TB that we see in majority. Other is cryptic miliary TB. So let us see what is happening. So consider this is your lung and let this be the various bronchi and let this be the alveoli. In classical TB, the TB bacilli will first come into the alveoli. Because of some unknown reason, they are not interested to stay in the alveoli. They go into the interstitium. From the interstitium, they go through bloodstream to various parts of the body. So this can occur as a primary TB or secondary TB. So what is going to happen if this is one alveoli? Suppose this is one alveoli, this is another alveoli. TB bacilli will first come into the alveoli, but because of some unknown reason, they are not interested to stay in the alveoli. They go into the area called as interstitium. From the interstitium, they can go into the bloodstream. From the bloodstream, they go to various parts of the body. And because the organisms are predominantly residing not in the alveoli, they are going into the interstitium. So sputum will be negative for AFP. And the classical feature is because they have spread to various parts of the body, even if you do eye examination, it will be showing choroidal tubercles. And on the chest X-ray, this is the description. Bilateral, top to bottom, side to side, 1 to 2 mm millet-shaped shadow. So you can see it on the chest X-ray very clearly. Now coming to cryptic miliary TB, let me explain you with a small case scenario. So this patient will be elderly. He'll be having chronic fever for many months together, weight loss and anemia. So whenever there is an elderly patient with long-standing fever, weight loss, anemia, there are two possibilities. One, you think it as chronic infection such as tuberculosis, or you can think it as malignancy. Because India is famous for tuberculosis, you try to rule out tuberculosis by routine investigations. And sputum will be negative for AFP. Chest X-ray will also be normal. Because sputum is negative and chest X-ray is normal, you feel that this is not tuberculosis. Because sputum is negative, chest X-ray is normal, why it will be tuberculosis, you will be thinking. But one day, patient will collapse and that will result in his death. Now you are interested to know what caused his death. Because you were evaluating, suddenly he died. So if you do an autopsy, it might be showing meningeal tubercles, suggestive of disseminated miliary TB. So this autopsy finding is showing that TB has spread to various parts of the body. But chest X-ray is normal. What might have happened? This is also miliary TB, but it was not visible on a conventional chest X-ray. Because to be visible on a conventional chest X-ray, the nodule size should be 1 to 2 mm. So this might be very, very tiny nodules which must have been hidden on chest X-ray. This is also miliary TB, but it was not visible on a chest X-ray, so it is called as cryptic miliary TB. So how to identify this patient? If you say take a CT scan, it might be visible. So here the nodules were very micro, very small. You could not identify on a chest X-ray because it is also miliary TB, but hidden on chest X-ray, it was called as cryptic miliary TB. And this is very, very rare phenomena, not seen nowadays. Classical miliary TB means on the chest X-ray itself, they will be visible. Whereas cryptic miliary TB means chest X-ray can be normal, but CT scan can show you the miliary pattern. So this is the classical miliary TB. One can notice top to bottom, side to side, 1 to 2 mm millet-shaped shadowing. Top to bottom, side to side, 1 to 2 mm millet-shaped shadowing. Coming to the various radiological features of tuberculosis. So I think you can easily identify this feature. So this is pleural effusion, and whenever there is escape of air into pleural cavity. I hope everybody can notice this. So this everything is blackish area. What is this blackish area? Air. Along with that, what you can notice? Compressed lung margin. So what is this combination called as hypertranslucent area without any bronchovascular markings? And you are seeing a compressed lung margin. So what is this? This is a pneumothorax, and you can see all this upper zone lesions. So this might be due to active tuberculosis complication. Now this can be called as a complication. And you can also notice in tuberculosis, sometimes they present with consolidation. So don't think consolidation will only be seen in regular pneumonias. In tuberculous lung involvement also, you can see consolidations, especially in the right lower lobe superior segment and right upper lobe posterior segment. And these are the TB infiltrates that we routinely see. You can see clustered nodules. So they are called as clustered nodules, usually around a bronchus. So clustered nodules. So these are all the clustered nodules that we routinely see in pulmonary tuberculosis. And on the CT scan, one feature suggestive of active TB is nothing but tree in bud pattern. So there might be something called as tree in bud pattern. There will be nodules. Now suppose this is the bronchus and these are the small airways. Normally they will not be filled with secretions. Because all these small bronchioles are also filled with secretions. Now this will appear like a branching of a budding tree. So can you see the similarity between these two images? See here. So they appear just like a branching of a budding tree. So this is called as tree in bud pattern. Centrilobular nodules. So nodules with a tree in bud pattern is classical of active tuberculosis, sometimes referred to as endobronchial tuberculosis. Endobronchial tuberculosis. And this is classical on chest X-ray. So once the disease sets in, you can see cavities. And generally they will be seen in the upper lobe. So these are all the upper lobe cavities, classical of active tuberculosis. And in few, one can notice miliary nodules. So these are all the various presentations. So a TB patient can present to you with pleural effusion, with pneumothorax, with consolidation, with clustered nodules. He can present to you with miliary pattern. Okay, all these are various features. And don't forget that sometimes TB can present with mediastinal widening. So TB can present with mediastinal widening. So why this is happening? Due to mediastinal lymph node TB. So mediastinal lymph node TB. So you can see this is the trachea. Surrounding the trachea, you should only find blood vessels like this. So this is a blood vessel. This is a blood vessel. Because it is filled with contrast, it is appearing white. So surrounding that, you are having enlarged areas where there is central necrosis with peripheral rim enhancement. Because in TB, there can be cavitation. Central part will be less dense. So there is central hypodensity with peripheral rim enhancement. With peripheral. If you see center, it is less dense. Periphery, it is bit more dense. So periphery, it is bit more dense. So peripheral part is bit more dense. This is called as central hypodensity with peripheral rim enhancement. So this is the basic difference between TB lymph node and sarcoid lymph node. In sarcoid lymph node, there will be no necrosis. So the enlarged lymph node will have only single or uniform density. Whereas here, you are having central part is less dense, whereas peripheral part is bit more dense. So this is due to necrosis. Coming to the management part. So whenever we discuss about management, first thing that you should keep in your mind is no longer TB is only having 4 drugs. So previously, many people used to mock at pulmonologists telling that your diagnosis will be having only either 4-COX or 4-OCOX. So 4-COX was the name of the drug brand of tuberculosis treatment. So it was containing HRZE. Because previously we were dealing with drug sensitive TB. So the people were thinking that we know only about these 4 people, HRZE. Now time has changed. No other branch or no other physician is dealing with so many antibiotics like this. So what are all the drugs available now for drug resistant TB? So you have bedaquiline, delaminide, pretominate, linezolid, fluoroquinolone, clofazimine, cyclosporine. These are only some. There is a big list later which I am going to share with you. So drug sensitive TB, drug resistant TB. Now the grouping of drugs for drug resistant TB is according to this guideline given in March 2021. This is a programmatic management of drug resistant tuberculosis in our country. It classifies the drugs into Group A. Group A, which contains levofloxacin, moxifloxacin, bedaquiline, linezolid. This is Group A drug. Group B drug, it contains clofazimine, cyclosporine. Can anybody name Group C drugs, students? At least 2 or 3 drugs, you let me know. So primary drugs are Group A and Group B. So Group A, we have levofloxacin, moxifloxacin, bedaquiline, linezolid. Group B, clofazimine, cyclosporine. WHO mentions that if you want to give proper regimen for MDR or rifampicin resistant TB, you should choose at least 2 Group A drugs and 2 Group B drugs according to WHO. But in India, we will be 1 step ahead. So India, what we do is we give all the 3 Group A drugs. So levofloxacin, bedaquiline, linezolid, and clofazimine, cyclosporine. So right now, for MDR TB treatment, WHO says 2+2, but in India we give 3+2. Coming to Group C, we have delaminide, amikacin, pyrazinamide, ethionamide, para-amino salicylic acid, ethambutol, imipenem. And these are the replacement drugs or reserve drugs. When the above drugs, Group A and Group B, are not working or they have become resistant, these are the replacement drugs. So for MDR TB, Group A and Group B are primary drugs, whereas Group C are the replacement drugs. And the replacement sequence will be also the similar one. Delaminide, amikacin, pyrazinamide, ethionamide, para-amino salicylic acid. Then coming to the TB regimens. In very simple words, TB regimens, as I have discussed previously, now it is drug sensitive, and drug resistant. Now let it be a new case or old case. If it is drug sensitive, the treatment and the duration will be the same. So what is the duration? It is 6 months. And what is the regimen? 2 HRZE plus 4 HRE. 2 months of isoniazid, rifampicin, pyrazinamide, ethambutol, with 4 months of isoniazid, rifampicin, ethambutol. So now we are also giving ethambutol in continuation phase. And this is a daily regimen. 2 months intensive phase. So this is called as IP. IP means intensive phase. And 4 months of continuation phase. Now coming to drug resistant TB, it is broadly divided into H resistant TB, also called as isoniazid resistant TB. Then we have the famous MDR TB. MDR TB means multi-drug resistant. MDR means multi. DR means drug resistant TB. So it is resistance to both H and R. Then we have XDR TB. XDR means extensively drug resistant. So it is MDR TB or rifampicin resistant TB that is resistant to 1-fluoroquinolone. Previously the definition was 1-fluoroquinolone plus injectable. But now it is plus either bedaquiline, linezolid or both. So any one group A drug or both bedaquiline or linezolid. So it is resistant to 1-fluoroquinolone plus either bedaquiline, linezolid or both. So that is nothing but group A drugs. So in XDR, if the patient is resistant to fluoroquinolone plus one additional group A drug or two group A drugs also, it is considered as XDR. So fluoroquinolone plus bedaquiline, XDR. Fluoroquinolone plus bedaquiline plus linezolid, it is also XDR. So XDR is nothing but ultimately resistance to the group A drugs. Now there is another term called as pre-XDR TB. It is MDR or rifampicin resistant TB, which is only resistant to 1-fluoroquinolone. So pre-XDR means something before XDR. XDR is fluoroquinolone plus additional drug. Whereas here only resistant to fluoroquinolone. MDR TB that is only resistant to fluoroquinolone. It is called as pre-XDR, pre-extensively drug resistant TB. There are also other words such as XXDR, extremely drug resistant, TDR, total drug resistant, but these terminologies have not been approved by the national body and also WHO. So what we have up to now is only XDR. So there is isoniazid resistant, rifampicin resistant, MDR, XDR and pre-XDR. So the treatment for MDR and rifampicin resistant TB will be generally similar. Now if it is isoniazid resistant TB, it is relatively simple. Because H is not working, we remove H. Instead of H, we add a fluoroquinolone such as levofloxacin and we give it for 6 to 9 months. In few situations, we may need to extend the treatment to 9 months or otherwise in majority 6 months will be sufficient. Now coming to the rifampicin resistant or MDR TB regimen. It is very simple, 3 group A drugs and 2 group B drugs. So it is that is longer regimen. But now we also have a shorter regimen. The primary difference is the duration. Longer regimen is 18 to 20 months. So like we have discussed, bedaquiline, linezolid, levofloxacin, group A, and clofazimine, cycloserine, group B drugs. So it is combination of group A and group B drugs. And it is stopped after 6 months. What is stopped after 6 months? Bedaquiline is stopped after 6 months. Now coming to shorter regimen. So shorter regimen can only be given when the exclusion criteria are not there. So here the duration of treatment is 9 to 11 months. The duration of treatment is 9 to 11 months. For the first 4 to 6 months, we give bedaquiline high dose isoniazid and ethionamide. ETO means ethionamide, levofloxacin, ethambutol, clofazimine, and pyrazinamide. In the next 5 months, we are going to remove bedaquiline, we are going to remove isoniazid, we are going to remove ethionamide. So these 3 are removed. So bedaquiline, isoniazid, and ethionamide. And we are going to give levofloxacin, ethambutol, clofazimine, pyrazinamide. Then what are the exclusion criteria for shorter MDR? So if you see the guidelines, so there are a big list of exclusion criteria. So patient exclusion criteria, then resistance pattern exclusion criteria, like that. But for ease of representation, I have divided into 4 headings. If the disease is very extensive pulmonary TB, and severe extrapulmonary TB, such as miliary TB, CNS TB. So in these conditions, just 9 to 11 months treatment may not be sufficient. So that's why it is excluded from majority of the trials. So if it is an extensive TB, severe extrapulmonary TB, EPTB means extrapulmonary TB, such as miliary TB, CNS TB, in these situations, what should not be given? Shorter regimen cannot be given, or any one of the drug in this is not working. So if there is resistance or intolerance or previous exposure to any second line drug in regimen. So these patients were given fluoroquinolones unnecessarily previously for some other disease. Now if he has been exposed to fluoroquinolones, high chances of resistance and high chances of failure of this regimen. And isoniazid resistance with both mutations, both CATG and INHA. For isoniazid, 2 genes are responsible. If both genes are showing resistance pattern, so then you cannot give isoniazid. And children below 5 years of age, still shorter regimen, and in lactation also shorter regimen is not given. Nowadays, we are giving it in pregnancy. Previously, pregnancy was an exclusion criteria, but in pregnant females, in few situations, we can start shorter regimen according to the new guidelines. So this is the simplest exclusion criteria you can find. So first thing, the disease perspective, it is a bad disease. Second thing, the drug perspective, resistance, intolerance, or previous exposure to the drug. And if it is isoniazid, the resistance is detected with both mutations, CATG and INHA. And children below 5 years and lactation. At least you know these are the exclusion criteria for shorter MDR regimen. Then coming to pre-XDR or XDR TB, the main difference is, so for MDR you have 2 regimens, shorter, longer. But for XDR and pre-XDR, you have only 1 regimen, longer. Here the longer regimen, it is 18 to 20 months. So here it is definitely 20 months. And it is the same drug. Bedaquiline, linezolid, levofloxacin, clofazimine, and cycloserine. And if at all, see, this is the basic skeletal framework. If at all any drug is resistant, now suppose levofloxacin is not working, you can go accordingly to the what you call the replacement sequence. So you can give delaminide, you can try amikacin, you can try para-aminosalicylic acid, etc. So regimen will be modified as per the replacement sequence. So what are the drugs used in replacement sequence? Again, it is delaminide, amikacin, pyrazinamide, ethionamide, para-aminosalicylic acid, all those. And as a last resort by NTEP, in whom effective regimen is not possible, it is called as BPAL regimen. So what is BPAL regimen? It is combination of bedaquiline, pretomanid, linezolid. So this is the last regimen that you can provide to a patient, and the duration is again 6 months. So this duration is 6 months. Now there are a lot of studies on a BPAL regimen. So it has been recently coming into limelight. So maybe in 1 or 2 years, there is also another regimen called as B-PAL-M with moxifloxacin. That might be the primary regimen. So, but now this B-PAL regimen is not primary regimen in our country. It has to be used only as a last resort in whom effective regimen is not possible. So in a nutshell, if it is isoniazid monoresistant, we give 6 to 9 months of levofloxacin, rifampicin, ethambutol, pyrazinamide. If it is shorter MDR or RRTB regimen, so intensive phase, continuation phase, total duration 9 to 11 months. So what to give, we have discussed. Longer oral MDR or XDR. Here there is no intensive or continuation phase. It is 18 to 20 months of levofloxacin, bedaquiline, linezolid, clofazimine, cycloserine. As a last resort, we generally give 6 months bedaquiline, pretominate, and linezolid. So these are the TB regimens that everybody should be knowing. So if somebody asks you, or if at all a question is given in exam, make sure you're not making any mistakes in drug-sensitive TB. Isoniazid resistant TB, MDR, RR TB, shorter regimen, longer regimen. You should know the names of the drugs, the duration of the treatment. And what is the last resort? Is there any regimen, any other regimen? Yes, it is B-PAL, bedaquiline, pretominate, linezolid. Then coming to TB treatment in special situations, we generally come across TB, HIV. If TB is the king, HIV is its famous queen. So in early stages, both are double trouble. In early stages, pulmonary TB in HIV will present in a typical manner. Just like the routine post-primary TB, it can present with cavitations. But in late stages, if at all patient is getting infected, in advanced immunosuppression, first time infection itself, it is going to disseminate. It presents like primary progressive TB with interstitial infiltrates because it is keeping on progressing. So it will not be localized at a single place. So generally cavitations are less common because it is progressing, pleural effusions, and there can be intrathoracic lymph adenopathy. So whenever there is TB HIV co-infection, according to new guidelines, no doubt this patient should get both TB treatment and HIV treatment, but both should not be started early because there is both should not be given simultaneously because it can cause a side effect called as iris. So what should be started first? So the guideline here is if ART is started first, there is a risk of immune reconstitution inflammatory syndrome. Now consider patient is having two diseases. So TB is high bacillary load and HIV is low CD4 count. Now suppose if you start ART first, antiretroviral therapy, suddenly the CD4 count will increase. Now this immunity has reconstituted. This reconstituted immunity will not keep quiet. It will see this TB bacilli and it will give an aggressive immune response, resulting in immune reconstitution inflammatory syndrome. Because of this inflammation, patient will again develop fever, lymphadenopathy. He will leave the treatment and run away. Here, prescribing the treatment is not important. Making sure he is tolerant to the treatment. Now, suppose another patient, again, TB with a high bacillary load, HIV with low CD4 count. Now, if you start ATT first, you are going to reduce the bacillary load. Now, after some time, say for example, minimum of 2 weeks. Now, if you start ART, even though the immunity is reconstituting, there is no sufficient TB bacilli to deliver that inflammatory response. So, patient's body will tolerate, he will settle down. There will be no this immune reconstitution inflammatory syndrome. So, the logic here is start ATT first and merge ART minimum of 2 weeks. So nowadays we are doing the same thing. If we identify TB and HIV together, so we are going to start ATT first and within 2 weeks we are going to give ART. So if ART is started first, what is the biggest disadvantage? It is immune reconstitution inflammatory syndrome. And don't think in HIV, always TB will present with cavities. So it can present with interstitial infiltrate, with more of lymph node involvement and with less cavitation. So this is in a patient with preserved immunity. So suppose his CD4 count is okay, not very bad. So you can see TB presenting in a typical manner, cavity. Whereas in a patient with low CD4 count, very bad immunity, so you can see some interstitial infiltrates. Again, TB can also present in an atypical manner when in HIV, when their immunity is not up to the mark. Then if a patient with HIV developing TB, so what were the old regimens? So we used to give ART this regimen. Now already patient is on ART, he is developing tuberculosis. Now how do you adjust the TB treatment? So previously patient was on this tenofovir, lamivudine, efavirenz or this nevirapine protease inhibitor. So this nevirapine protease inhibitor regimen, it was having a lot of interactions with rifampicin. So instead of rifampicin, we were giving rifabutin. But now things have changed. Now the new star in ART, D, it is D. Just like this woman, she is Deepika D. So what is that D? It is dolutegravir. So because we are giving dolutegravir, now what we are going to do is, it also have some interactions with ATT, especially rifampicin. So we are going to give double dose of dolutegravir. Suppose we are giving 50 mg of dolutegravir previously. Now if we are giving ATT to this patient, because it has interactions with ATT and its metabolism might be quicker, so we are going to increase the dose of dolutegravir from 50 mg to 100 mg. So double dosing of dolutegravir in combination with rifampicin containing ATT. So this is very important if it is drug sensitive TB. Now if it is drug resistant TB, dolutegravir can be given safely with bedaquiline delaminide. DLM is delaminide in DRTB. So previously, instead of rifampicin, we were giving rifabutin in few situations. Now no need to change any ATT. So just give double dose of dolutegravir if it is drug sensitive TB. If it is drug resistant, especially when rifampicin is not given. So with other drugs, bedaquiline, delaminide, there are no significant drug interactions. So this is very important in ART, ATT. Two things. One is immune reconstitution inflammatory syndrome. And the second thing is TB can also present in atypical manner. Coming to the treatment, now we give double dosing of dolutegravir. Coming to ATT in pregnancy. First thing, if it is drug sensitive TB, keep this in your mind as long as in your India. Drug sensitive TB, no change in TB treatment in drug sensitive TB. So if you open some Western textbooks, they say that pyrazinamide should not be given. No chance in India. If there is tuberculosis in India, you should give for drug sensitive TB the usual regimen. There is no modification at all. So no need to modify any drug. Previously, when we are giving streptomycin, we were thinking of modification. Now no streptomycin is used in drug sensitive TB. So usual regimen will be HRZE. Now coming to the complicated topic, drug resistant TB. So if you open your PMDD, so this will span about 2 to 3 pages. Let me simplify it in a single slide for you. So drug resistant TB, you need to modify a few things. First of all, you need to find out whether this patient is fit for medical termination of pregnancy. Now, the age for medical termination for gestational age is 24 weeks. If it is less than 24 weeks, especially we are talking about, here will be MDR and XDR TB. If it is less than 24 weeks, best is advising MTP. So what is meant by MTP? Medical termination of pregnancy. So if MTP is done, you can start shorter bedaquiline-based MDR TB regimen, if at all there are no exclusion criteria. Now suppose age is less than 24 weeks and patient is not willing for MTP. You have to follow next column. Now let us see what is next column. Suppose the fetus age is more than 24 weeks. It means it has crossed the age of MTP. Now you have to see whether it is less than 32 weeks. So next number here is, first number is 24. So why 24? To see whether you can do any MTP. Next important number here is 32, less than 32 or more than 32. So why 32? Because ethionamide has shown to cause some teratogenicity and some effects on the fetus. So ethionamide is strictly contraindicated during first 32 weeks. First 32 weeks. So this 24 weeks has happened after PMDT 2021 edition has come. Okay. So this is now it is 2023. So now 2023 government has given that MTP can be performed at 24 weeks. So this is a recent new article. Okay. So PMDT was in 2021 when the gestational age 20 was accepted. Now it has been changed by government for 24 weeks. So it is according to the recent guidelines. Now ethionamide cannot be given less than 32 weeks. So if it is less than 32 weeks, then you have to give longer MDR-TB regimen, because longer MDR-TB regimen does not contain ethionamide. So what does longer MDR-TB regimen contain? So it contains bedaquiline, it contains clofazimine, it contains cycloserine, linezolid, and levofloxacin. There is no ethionamide. But whereas shorter MDR contains ethionamide. So if it is less than 32 weeks, you cannot give ethionamide. You just give longer MDR-TB regimen. If it is more than 32 weeks, so you sit with the gynecologist, you sit with the patient and discuss and come to a consultative decision, and you can start either of this regimen, either longer or shorter MDR-TB regimen. So here in simple words, if eligible for MTP, practice MTP. If not eligible for MTP, if less than 32 weeks, you cannot give ethionamide. Because you cannot give ethionamide, you cannot give shorter regimen. Just give longer regimen. If more than 32 weeks, you can give either longer regimen or shorter MDR-TB regimen. So next important is TB preventive treatment in India. So even though the guidelines have given to do MON2 test and also this interferon gamma release assay at program level, at the basic level, this is the simple guideline. So if there is a patient living with HIV, active TB has been ruled out. Living with HIV, active TB ruled out, and household contacts of pulmonary TB patients. HHC means household contacts. Already it was discussed in the PSM part today. So these two patients should be definitely given TPT. TPT means TB preventive treatment. Along with this, the program is also targeting who are individuals at risk of developing tuberculosis. So these are the individuals on immunosuppressive therapy, anti-TNF treatment, organ transplant, silicosis, dialysis. So, but as of now in program, these two people are routinely given TB preventive therapy. People living with HIV when active TB is ruled out, household contacts of pulmonary TB patients. And maybe in the coming future, it will be extended. Though the guidelines mention that to extend to these patients also, maybe because of inadequate drug supply or staff, it is not still done at many places. So who are the other individuals? Immunosuppressive therapy, anti-TNF treatment, organ transplant, silicosis, dialysis. And what is the preferred regimen? Preferred regimen is 6H. 6H means isoniazid. So 6 months of isoniazid. So 6 months of isoniazid. And the maximum dose is 300 mg per day. And we are also thinking of introducing this regimen called as 3HP. 3HP means 3 months duration, but this is weekly. weekly isoniazid and rifampicin. Isoniazid and rifampicin. Because we are giving once a week, the dose will be higher. So 900 mg of isoniazid and 900 mg of rifampicin. Right now in India, we are giving this 6H regimen, 6 months of isoniazid as a part of tuberculosis preventive treatment, So these are the two regimens. 6H is 6 months of daily isoniazid. 3HP means 3 months of weekly rifampicin plus isoniazid. 3HP. So they might be asking you the doses. If it is daily isoniazid, we give 300 mg. If it is weekly, it can be given up to 900 mg. So with this, we are done with the basic concepts of tuberculosis. So we started with the PSM part. So then we went into the clinical part. We have discussed what is primary TB, what is secondary TB, miliary TB, pleural TB, the complications, radiology, and important regimens required for any standard exam students.